Good afternoon or past noon, everyone. I'm happy to be here today to be given the opportunity to talk to you about an interesting subject to me and an important subject, I think, for the people living with diabetes. So I'm an endocrinologist who has a lot of actually a big part of my practice that is centered around diabetes. I see patients at the Human RCM, and I'm also a researcher. So let's start. What's going to be on the agenda today? We're going to try to define together what's LADA, what's the evidence on the genetic and environmental predispositions to LADA, why should we focus actually on a better understanding of this entity, what is the opportunity that the Better Registry is offering to us to answer certain questions, and what do some preliminary results of BETA show about the LADA. So I'm going to be sharing this with you today and just sharing also next steps and projects along the way. Would be happy to answer your questions and comments at the end of this webinar, and please go ahead whenever I'm presenting, type your questions in the Q&A section, and we're going to go over them as much as we can by the end of this talk. So let's start a little bit with what we know about diabetes. So diabetes is this very heterogeneous disease, so that's in general, and we've always talked about the two main types of diabetes, so type 1 diabetes and type 2 diabetes. And what's the main features of what we call classic type 1, classic type 2 diabetes is the fact that type 1 diabetes, the classic one, is an autoimmune process that disrupts or kills the beta cells in the pancreas that secrete the insulin, and the person is deficient in insulin with this pathology. And that with type 2, it's more a dysfunction of the beta cells, but also there are several insulin resistance that is related to other pathologies or axis of pathology in other organs like the liver, like the brain, like the intestines, the adipocytes, and the muscles. So the idea generally of diabetes is that people who are younger, leaner, have probably a type 1 diabetes. People who are older, have some overweight or obesity, might have the type 2 diabetes. But what we know from every now and then, like with the progression of our understanding of diabetes, actually, is that it's a very heterogeneous disease, as I said. And there are some types that are confused with classic type 1 and type 2. For example, there is one type of diabetes that is called MODY, or maturity onset diabetes of the young, and this is monogenic. So there's just one gene that is responsible, a mutation in one gene that we can identify that is responsible for the pathology of diabetes. And we know that there's LADA. LADA, so it's latent autoimmune diabetes of the adults. And this is what we're going to go over today and discuss. And it's important to know that it's a polygenetic and environmental disease. So we have the predisposition, and there are some environmental factors, a bit like in type 1 and type 2. And LADA, it's between the two and also is a heterogeneous entity. So how do we define LADA? Actually, this is where the problem is that this is not an entity that's clearly defined in the literature, even among the medical professionals and health professionals. There are multiple criteria according to different societies, endocrine societies or diabetes societies, and different definitions. And sometimes you're going to come across terms like type 1.5 diabetes, hybrid diabetes, subtypes of type 1 diabetes. So all these terms really refer to what we know as LADA. What I would like you to retain, or like to keep in mind, is that what we can define actually for LADA is that it's an autoimmune process. So there is some destruction of the beta cells, but that is very slower, or like slower than what we see in classic type 1 diabetes. And the need for insulin replacement is variable in timing and even intensity. How much you need insulin is variable in timing and intensity compared to the classic type 1 diabetes, and between each and every patient who is living with LADA. And that we can identify autoantibodies that are markers of this autoimmune process, and there are many autoantibodies that we can look for actually. Let's go a bit over what are the antibodies. So even if we talk about classic type 1 diabetes, I thought of putting this slide because just it's interesting, it would be interesting to see what we talk about when we talk about antibodies, what are we looking for actually? So antibodies are proteins that are directed against certain proteins that are in the beta cell, that secrete insulin. So you can see the beta cell like here in this diagram or in this figure. And these are proteins that are usually involved in insulin secretion, in beta cell survival, and inflammation around the cell. So here's I put some of the years during which we could identify the different type of antibodies in type 1 diabetes. You might have heard of the one that's mostly used, and that's actually the only one that we can dose in Canada, even worldwide sometimes, most of the time. And it's the LADA, or anti-glutamic acid decarboxylase. And if you look at the figure, actually, you can identify. So the insulins here, like these are the secretory vesicles of the insulin. So we have antibody against this, And this is another protein where we can find antibodies. This is another. These are like some transporters across the secretory vesicles. You can see that the GADA also is part of the secretory vesicle. So these are, the antibodies are directed against these proteins. So in LADA, what's so different from other types of diabetes is that its features of this diabetes could be common to type 1, what we see in type 1 in classic and in classic type 2 diabetes. So in consequence, actually, what we have is a loss. So diagnosis is not clear at the beginning, and there is a certain time delay before making the correct diagnosis. Most of the time, these patients are classified as having type 2 diabetes, are treated as such, while the pathology of their disease and what's going on is a bit different from what we know as type 2 diabetes. And this comes with a price, because there is some effect on the quality of life and the diabetes management of these patients. And actually, some data that's important, that shows us there might also, this delaying diagnosis might implicate or might result in increased rates of diabetes complications. So let me share with you actually this data from, it's a UPPDS cohort, it's a type 2 diabetes cohort. And what they did, so this is a very old cohort, it's very, very large, it's in the UK. And what they did actually, it's a recent analysis. They looked back at the data in 2020, and they did antibody testing for certain patients. They did actually 3 types of antibodies. So it's in research context. And if one is positive, diabetes was reclassified as LADA in this patient, because we have proven that there is some autoimmune process going on. So, and they took all the participants that have tested positive for antibodies, one of these antibodies, and that at inclusion in the UKPDS cohort, they did not have any baseline microvascular complications, and they were followed up in the time. So they could identify 564 participants or patients who have LADA. So that's 12% of this cohort, this sub-cohort, let's say, and 4,500 with type 2 diabetes. What I want to show with you or share with you is the fact that at the inclusion in the UKPDS cohort, there were fewer microvascular complications in the first 9 years after diagnosis if we compare these to the type 2, the patients who did not test positive for any antibodies, but that this rate significantly increased to exceed like 20%, 25% more that of type 2 after 9 years. And this was linked to higher hemoglobin A1C in these in persons who have lived with LADA. So this means that this delay of adequate treatment in the first stage of diagnosis exposed to the patients to hyperglycemia, exposed them to developing risks of microvascular complications, which probably if they were treated as they should with the right diagnosis, we could have like delayed the appearance of microvascular complications. So why it's important also to look for LADA, because actually it constitutes up to 10% of all diabetes cases. So if you still look at the diagram here, it's not part of type 1. So we already know that type 1, the classic type 1 is around 10% of all cases of diabetes. In the gray area, we have like the classic type 2. And you see that the clear blue here is the LADA. So it's around 10% of all diabetes cases. And that's a lot. That's almost like equivalent to the classic type 1 diabetes. And it's an entity that we don't understand fully, that we don't treat as we should. More importantly, also, like if we look actually, as I said, like in the beginning, we test only one antibody, and we have access to one antibody in Canada or like in Quebec in Canada or even many countries. Because there aren't assays that are like commercially available to everyone. There's the cost, is it efficient, is it, all these questions. So for the time being, we only test for GATA. And some research studies that went to look more into the significance of that, they showed that the presence, so just testing positive for different antibodies or the level of the titers of these antibodies have been shown to be linked to some phenotypic differences that we see across patients who have LADA, because these are patients who are like across a spectrum from type 1 and type 2. And they could be associated with the faster progression or slower progression of insulin deficiency. So they have some value in telling us where the person is on the spectrum and how we should treat them probably. Just to give you another example also why we need more antibody testing is actually in 2 European and Chinese cohorts of patients with recent diagnosis of non-insulin treated but autoimmune diabetes. So we tested antibodies. The GATA was positive in 90% of European cohort. 10% of this cohort, they had other antibodies that were positive other than the GATA. So these, when we only have GATA, they were missed as having an autoimmune process. Even more in the Chinese cohort, so it depends on the ethnicity of the people as well. We can see that only 67% of these participants had GATA positive, and they were positive for the other around 33%. So that's a big number that we could miss if we don't do better at having access to more antibody testing. So what's the genetic predisposition actually to LADA? I would like you to know that several studies have been done, and many have shown that there are some genetic components that put the person at risk, or variations in the genes that are common between LADA and type 1. These are few of that I mentioned that are very, very well known for type 1 and also with type 2. So the TCF7L2, actually, it's one of the genes that it's like the highest gene that confers the risk of type 2 in the GWAS, genome-wide association studies that are like probably the most robust at the studies. So this might tell us that if we can get some kind of genetic risk score that will look at the patients carry which of these genes that are either common to type 1 or type 2, we can get a certain possibility of a score that could stratify also where the patient is on the spectrum and what's the rate of progression in pancreatic reserve loss. So what about actually environmental factors? The question comes to mind. So with phenotypes that are similar to type 1, that are familiar to type 2, can environmental or lifestyle factors other than genetic predisposition drive LADA by triggering autoimmunity and or inducing a certain insulin resistance? So this is a very valid question. Unfortunately, we don't have yet data to answer this. There's lack of evidence because we didn't look at this question as we should. And literature review highlighted some observations. So I'm sharing with you one literature review that was interesting, that was published in 2019. And actually, although we know of LADA for so much time now and everything, there were only 15 articles between 2004 and 2017 where we could that in this article, there were some description about incident cases of LADA and environmental factors. But also look, they were only based on 2 cohorts that are in Norway and in Sweden. So actually, we lack big cohorts of LADA also worldwide. So let's start with the obesity. So a BMI was higher in LADA than type 1, but it was lower than type 2. For a low birth weight, so actually it's the effect of the in utero. So in utero, when the baby is growing, there's some effect, the metabolic effect actually. And if they were had low birth weight, they were also associated. This was put the persons at twice the risk of developing LADA compared when we compare less than 3 kilos versus 4 kilos at birth. And if we combine the two of the BMI and the low birth weight, it's almost tripled also the risk of developing LADA. Physical activity, the data we had, they were comparing just less than 1 per week or at each day some physical activity, and also it was associated with a high risk of data, but with LADA, but it was a small number of patients in this study. tobacco, there were actually contradictory results. So we couldn't tell if it affects some showed it might increase, some showed it might decrease. Alcohol, actually 12 to 24 grams a day, had some protective effect, and probably this is via improved insulin sensitivity. But also, when we looked more at the data, it was associated with higher titers of data. So it works in different ways, the same way that also LADA is between the spectrum of type 1 and type 2. So probably the icon effect is going to be different a bit from one person to another. Coffee, there was controversial data, possible increase risk of LADA with coffee, but it was also associated with higher GADA titers, so the antibody. Omega-3, so the fish consumption of fatty fish, 2 servings per week, there was probably some possible protective effect, we can say, and it's some immunomodulation of LADA in this patient. Why is it important actually to study LADA? With all the information that I've shared with you so far, I just would like to tell you that there are no clinical guidelines for LADA. So when we look at the clinical guidelines, whether here, whether in the States, whether everywhere, like we talk about type 1, type 2, insulin therapy, how to try the other molecules that we use for type 2, but we never say anything that is very specifically directed to patients who have the profile of LADA, of latent autoimmune diabetes of the adults. So it's important to study actually therapeutic molecules like DPP4 inhibitors, GLP-1 agonists. These are probably molecules that SGLT2 inhibitors. These are molecules that are new molecules that are used in type 2 diabetes, but we know that they might be very useful actually for LADA. There are some molecules that we call immunomodulators, so they might affect the immune process that are under study for type 1 diabetes. So we might actually think that these probably anything that might slow the autoimmune process might be even more important or like more effect when we have a slow autoimmune process like in LADA compared to type 1 diabetes. But most of the studies with these immunomodulators also are done in classic type 1 diabetes. If there are some LADA inside, yes, but they were never like studied for LADA per se. Any effect of lifestyle also that we should look at. Anything that we can say like what we care about, what we want to look at, and what we are after is actually anything that might have the potential to preserve the beta cell function and prevent diabetes-related complications the longer possible. So here's I'm sharing with you actually the BETTER project. So you're all familiar with it. And what's interesting about BETTER, the way the questionnaires were done, these are self-reported questionnaires that you fill when you get prescribed or when you register actually. And actually within the questions, there's the first question, actually, one of the first questions is what type of diabetes diagnosis did you have? Whether it was just the type 1 or whether you received the diagnosis of LADA. As you know, also with the questionnaires, we have a lot of data, like clinical therapeutic characteristics, life habits, comorbidities, complications that we could also analyze. So this is a project that we started and we looked at, we had the objectives of describing clinical characteristics of the cohort of patients diagnosed with LADA and that are enrolled in the BETTER registry, also to compare these with patients who have the classic type 1 diabetes. So this is an ongoing project, but I would like to share with you some preliminary results. So the first 1,460 participants, we looked at their data to see if we should go further or if it's worth, we can see some differences that we can try to expand when the registry expands as well. So this is what I'm sharing with you here. So you can see that we had among these 1,460 participants, we had 131 who had declared having a LADA in their question. So that's 9%, and that's a figure that is similar to what I showed you in the literature when the right diagnosis, when antibodies are looked at. We had around 62%, but it was whether type 1 or LADA. So it reflects what people, like the females, were more participant in this, in the registry so far, like with this actually the first 1,460 participants, but it doesn't mean that LADA is more like, or type 1 that is more incident in female. It just reflects what people who participated in the questionnaire. But you can see that we have comparable between the LADA and type 1. You can see that the age at the registration, we had the type 1 were younger than the LADA participants. Age at diagnosis was a bit higher. So it's 39 compared to 18 in type 1 diabetes. Diabetes duration was a bit higher because it comes at earlier age in this cohort as well, 24 versus 10 years of diabetes. Interestingly, look at this. So we have the family history of type 1 diabetes was even higher in LADA participants than in type 1. And that's interesting because we know that there is this genetic predisposition also in these patients. So far, we have more Caucasians, but probably when we are expanding to Canada, probably this figure might improve. And we are hopeful that we can recruit more and more people from other ethnicities. And we have a rich community here. So I think that's what will be also different about better is that in Canada we have different ethnicities that we can build better also cohorts. And let's look a bit at the insulin therapies and technology used in patients with reported LADA versus the classic type 1. So you can see that the initiation of insulin therapy during the first year post-diagnosis was a bit lower. So actually half of the patients only started insulin within the first year. The other half they started after the first year of diagnosis. And this is compared to almost 100% of patients who declared classic type 1 diabetes. We can see that both type 1 and LADA had comparable use of glucose sensors, but where we can find the difference actually in insulin pump users. We have a higher rate in classic type 1 versus LADA. We just need to keep in mind that this figure also might result from the fact that type 1 is more in infant, in adolescent, and in childhood, and there's the Quebec program to give insulin pumps access to this age group. But look, for example, at carbohydrate, meat counting was less in the LADA than in patients who have declared type 1 diabetes participants. Let's look a little bit about the glycemic management and increased complications. So with HbA1c, we didn't see significantly difference across different ranges of HbA1c between classic type 1 and LADA. But hospitalizations over last year, so at registration, we can see that more LADA participants had the hospitalizations related to their diabetes, and more had ketoacidosis also related to their diabetes. So that's alarming figures, actually, you can say. About hypoglycemia, so here we were looking at, the question was phrased to look for hypoglycemia that's below 3 millimole per liter, so it's serious hypoglycemia, but that was somehow still self-managed by the patient on the first part of the graph. So you can see it was less in type 1, in LADA. For severe hypoglycemia was also less in LADA, and this might be also due to the fact that people with type 1 have lived longer also with their duration, with their diabetes at the time of registration with the better. But it's also interesting to see that 8% is a big percentage with severe hypoglycemia, meaning that the hypoglycemia that necessitates hospitalization or help by a person, a friend, a family, and use of a glucagon or loss of consciousness. So that's serious, that 8%, it's high. Despite this figure, we can see that when we looked at the glucagon use in participants who had LADA, we had much less knowledge, prescription, and accessibility in LADA compared to classic type 1 diabetes. Let's look now a bit about a comparison of complications and comorbidities between type 1 diabetes and LADA. So what we can see is somehow, also with LADA, we had a good percentage of participants who had complications, had short complications. And what we could see is that type 1 diabetes had more microvascular complications, nephropathy, retinopathy. But you have to remember also to put in mind that in this cross-sectional analysis of participants who registered with better, there were longer years of diabetes in patients with the classic compared to LADA. Neuropathy, gastroparesis with ulcers, they were also common in both diseases, but they were comparable. The presence of other autoimmune diseases, you can see also that problems with hypo or hyperthyroidism, so thyroid problems were more reported by participants who had LADA compared to others, and the rest were a bit comparable between the two. So as I was like telling you all these results and stuff, I was like alluding to the fact that there were differences in age at the time they registered. There was differences in the times of years of living with diabetes also. So to answer these questions in a better way, actually, and to be better able to compare LADA to type 1 diabetes, we have to match for duration of diabetes and for sex, okay, to see the difference. And we could do some matching with this first analysis, but what the matching would be much more interesting when we have more participants, so a higher N for our analysis. And when we did some matching to diabetes duration and sex, so we take people who have declared LADA, and we take people who have declared type 1 diabetes, but who had the same years of living with diabetes compared to LADA. And here, for example, rates of retinopathy and nephropathy became comparable between the two. But what emerged as a difference was that cardiovascular diseases were more in LADA than type 1. But here again, also, if we have to remember that LADA were older people than type 1 diabetes. So when we have a higher N, what we could do is to match for duration of diabetes, hopefully also like the age at diagnosis and the sex. So that way, like we can get the best comparison between LADA and type 1 diabetes, the classic type. So our objective actually is to answer many questions, or like to look at many aspects. So we need to have a better classification and detection of LADA. We need to identify respective risks of developing acute and chronic complications in people who have the LADA profile compared like just to the classic type 1 diabetes. We need also to optimize personalized support strategy. So how to treat a person, how to manage their diabetes when they have profile of LADA instead of the classic type 1 diabetes. And the most important question, since it's a slow autoimmune process, so is it possible more, or we have more chance of actually preserving the beta cell function, delaying the autoimmune process, slowing it when we have a profile of LADA compared to type 1 diabetes? And just to tell you that most of the studies that are done usually with classic type 1, probably affiliated with some cases of LADA, but the data that we're getting out is like mostly for type 1 diabetes, the classic type. So here's the diagram also that shows how we are formulating our objectives actually, and what we're looking at, or what we're after actually. So I showed you the project 1, which is the characterization of LADA in the beta registry, and now we're waiting for data extraction for over 300 and 500 participants, and the 9% rate of LADA is maintained actually in this cohort. So we have around 250 participants who have declared LADA. And this will make us much able like to see differences, to do better matching, to get better results and better comparison. Another project that we would like to have is what we call machine learning. So we can take patients who have classic type 1, classic or just take all the cohort that has autoimmune diabetes of the adults, and then run certain characteristics that we can get about these participants in machine learning. So it's artificial intelligence programs that could separate the persons into subtypes. One of these subtypes probably is going to be LADA, but probably there are other also subtypes in type 1 in general that we hopefully detect. So this is a planned project, it's not done yet. And most importantly is that we hope that we are now building a LADA cohort that's across Canada. And this will allow us to do intervention trials. So try to answer the questions about the different molecules. Just to give an example. So the patients who have LADA, most of the time they are seen by primary care physicians. And primary care physicians are not necessarily very sensitized to the idea that there are different subtypes or different classifications or different spectrum of diseases. And we need to tell them when you have a patient, when to detect, when to go and test for antibodies, hopefully having more antibodies actually to test. And also we need to tell them what you can start your patient on. So we know that, as you saw, it's not within the first year that everyone needed insulin, but which molecule, so which pill is more important to start with, since, like, for example, in type 2 diabetes, we have like guidelines that tell us start with metformin, add sulfonylureas, then the GLP-1, then the DPP-4. But what we know more and more that probably these molecules need to be started at different timing, and probably the DPP-4 might be very important to start with, like in LADA. We don't have, so these are still ongoing trials, or like actually we want to do many of these trials because we don't have clear answers even to give to our primary care physicians at this stage. So just I want to like expand a little bit on the project one, just to tell you where we are. And with the sake of the time, we can't go over the rest of the projects. Hopefully we'll come back for other presentations. So we're going to do a matching for sex and duration of diagnosis with our new data. We have also to match for sex and age at diagnosis. And what we're going to do is actually all the people who register with the Better, fortunately, they are asked if they would like to be recontacted for future projects. And interestingly, luckily, actually, also, and they are very thankful, more than 95% they accept to be recontacted for future projects. So these participants, we're going to contact them, the ones that have LADA and those who are matched with them for duration of diagnosis and age at diagnosis. And we're going to go for more targeted questionnaire to collect more data about glycemic control, treatment of complications, what treatments they are on and everything, and when did they start. But also, I think this part is going to be like very rich. It's going to give us much information, is to have some structured interview with these participants to identify the context of their diagnosis of LADA. So, and if there was a very long delay before telling them that it's actually LADA, not type 2, and to see also what was the impact of all this diagnosis, all this delay on the participant's life. So these are, I hope we can get, like when we have 250, if 100 we could collect, or even 50 participants, we can collect enough information to tell where are we failing in diagnosis. What was the profile of these participants at the development of their diabetes? Can we get like clear criteria to give actually to our primary care professional, health professionals, about what the profile of patient need to be like alerted that this is not a type 2, but probably another form, which is probably a LADA as well. So we hope to get answers with this approach. We are also gonna collect more data about the genetic risks, also the antibodies, and this is, as I said, just within research for now. But once we get this type of information, we can influence we can push for testing of antibodies more general and different types of antibodies, and not just GADA. But we need the data, we need to show it, and we need to tell them this is what we need, what we want to be done. So to conclude, actually, as you saw, there are many questions that remain to be answered. So what's LADA actually? What's the best screening strategy? What are the best management and support strategies? How to preserve beta cell function for as long as possible? These are important questions that we need to answer, whether us, whether other groups, but at least somewhere it should start. It doesn't mean that it's not started, as you saw, like there are cohorts in Europe, Scandinavian countries, but there are also some in China. In Canada, we would be probably the first to lead this. The Better project offers a great opportunity because, as you saw, with the preliminary results, you can see that there's potential of getting more information, of adding and building a prospective cohort that we can follow in time also. So we hope to advance the research, try to answer some questions. We try to benefit the patients living with LADA, whether here or all over the world. So I would like to thank actually all the participants. Without them, I'm sorry, the first one is in French, so it's actually all the participants into the studies. My mentor also, Dr. Rabaz Aloqi, who you might also recognize and know as the leader also of project, Dr. Anne-Sophie Brazouki, who is also a leader of the Better project, all the investigators, all the people who work with project, whether students, whether they're researchers, whether assistant researchers, and all the organisms also that have supported better. There's also one funding actually from the Centre d'Expertise en Diabète SED du Ocean, and it's gonna like also help us advance the first project at least, and then probably we'll ask for funding for the other projects. Or also the colleagues, collaborators, especially like Mrs. Yves Poirier, who's a partner actually as a patient who have lived with LADA, Mr. Michel Dosti, and all the other colleagues as well. So I would like to thank you for attention, and I would be happy to go over the questions and comments. So I'll just open the Q&A. All right, so the first question is, how can I find out if I have LADA or type 1? So as I said, like it's gonna be probably like a good questionnaire of what you have. One of the things that I did not probably mention clearly in my presentation because of the lack of the time is that we can also look, so we can ask about questions about how it progressed, your diabetes, when you started insulin, how your needs of insulin also progressed over since you were diagnosed with diabetes. And we can look also at the peptide C. So the C or C-peptide. C-peptide is actually a marker that we can measure in the blood, and it can tell us about the function of what's the reserve of the pancreatic cells. So what's remaining actually as auto-secretion of insulin in your body. And so it's one of the things I would go with peptide C and C-peptide and just measure it and look at your profile, how did it progress over time, and whether at what age you had it, at what was the context, and what are your needs in insulin, and also like what are your complications profile. Another question, thank you so much for your work. I have been diagnosed this past year, and participating in this study helps me have hope for the future. Thank you very much for listening, and thank you also for appreciating this. Yes, exactly. Like we are very, very happy. We are very, very. It's very important to participate in the better registry because otherwise we cannot advance. So we really thank you all, like for all your engagement, without which we can't advance. So I think that's it. I don't know if you have other questions coming in, Natalie, that I couldn't see.
No, I don't see anything else.
All right. Perfect. So so if you have any questions, also like you can always go back, ask us through the better registry. I would be happy like to answer further questions if they come up. Okay, so there's one coming. See that tobacco is not showing up as a risk factor. However, low birth rate is a factor, and this is more exactly like, so what I showed you, actually, we have very, very, very limited data about so I showed you what the things that we should look for. I totally agree. So the tobacco data was fluctuating between protective or not. And that's probably the reason is the small number of participants where we looked at this question. And exactly, so it is related actually to low birth weight and might put the person at higher risk. The thing is, like, probably with bigger cohorts, we can better answer this question. I can see peptide be an indicator for LADA. Yeah, if C-peptide is high, actually, it's not very, very low doses. It can tell us that this is a slow progression of type 1 diabetes. If you ask me, do we have thresholds or clear numbers to share with you? I would tell like anything that's probably like it's a value probably more than 0.1, but we don't have like very, very clear numbers. What we know is probably like if there is some reserve, the C-peptide level will be higher than when we have a classic type 1 diabetes. Most of the time we have less than 0.1 and even less than that. Like sometimes it's not detectable even in classic type 1. So if we see some C-peptide that's present, it can reflect probably a profile that's more LADA than classic type 1 diabetes. But we need more data actually. So that's the thing we're gonna try to collect. If you collect C-peptide levels in the people who have declared LADA and compare it, are we going to be able to set a threshold that will help us more tell which is which? Probably like this is what we hope, like at least. All right, so another one, my son 21 was lower birth weight and now has a higher BMI. Is he at risk? I was diagnosed with type 1 during pandemic at age 50. Yes, actually, this is one of the things that when they looked at the fact that BMI was high and they combined this with a lower birth rate, the risk was a bit higher of LADA than either or alone. So if you were diagnosed with type 1 during pandemic at age 50, also like probably you might have also yourself a profile of LADA or just the classic. If your question is, if your son is interested in knowing his own risk of developing type 1 diabetes, whether with the LADA profile or the classic, there's the TrialNet, actually a group who offers some antibody testing for relatives of people who have diagnosis of type 1 diabetes. So you can go just TrialNet and try, like they have certain, they might send even for free. It's based mostly in the States and with many centers, but there's also like one center in Toronto at the Sick Hospital, Children's Sick Hospital. And he can ask to be tested. They will look at his antibodies and they do actually all the antibodies, the 4 antibodies. And he could have like actually a follow-up. He can participate in the studies that are preventive, that are ongoing with the TrialNet group. All right, so I think that concludes it. As I said, I would like to thank you again for your attention. And if you have further questions, you can also ask later on through the Better Registry. And I hope to come back with hopefully some answers to what we have discussed today. Thank you so much. Anything to add, Natalie, or I think we can close?
No, that's all right. We can close everything up.
All right. Thank you, everyone. Have a great day.